Once again, a very, very warm good morning, grateful morning, prayerful morning, and a lovely morning to each and every one of you present here. Thank you for being here. Very excited to see all of you, and especially nursing students. Cygnia Healthcare is committed to zero harm, and we have done this publicly on the website of Patient Safety Movement Foundation USA. And with that, to help nurses and nursing and our patients, of course, we have initiated this series called In Pursuit of Patient Safety. And that is what, and we had conducted one learning through Q&A, I think it was last month. And this is the part 2 of that. We are trying to keep it just for 1 hour. Last time we had 2 hour session, and this time we are trying to have 1 hour session. And this week is very special because Patient Safety Awareness Week is being celebrated from March 13 to 19, and we are doing 3 such sessions. One is today, 1 hour, and tomorrow we'll again meet at 11 a.m. discussing about another topic, and on 17th as well. So we would love to have you back here and pick up some very practical and relevant knowledge that you can have to make yourself safe and patient safety. And let me remind you one thing, my dear nurses, is that if we practice safely, we not only ensure that our patients are safe, we also ensure that we are also safe. So always keep that in mind. You want to be a safe nurse, do safe things for our patients, and nobody wants to make a mistake. So this is very important to know that all the knowledge that we gain, how do we translate that into application? That is the most important aspect of being a nurse, that how do you apply knowledge to our workplace. So without any further delay, let me just pull up my presentation and we will start. So let me go to the presentation. Just give me a minute. Okay, can we all see the screen? Can you all see the screen? Just raise your hands. Thank you, Ishita, for being here, and please request everyone to stay muted and stay off the video also. And once we finish, then obviously we will allow anyone to come on the video. We'll finish the recording as well. So let's start with our session now. As I told you that today is the part 2. The part 1 has already been uploaded on the YouTube, and it's also available on our academy site, where you can go and take the test also if you want. Okay, so please mute your microphone and please keep your video also off, because that will disturb the recording. So I would love that you keep the video off. Thank you very much. And questions can be typed into the chat box and we will try to answer them at the end of the session. So as I'm talking, in case any doubts, any questions come to your mind, just put it in the chat box, so we can help you with that. So we are doing this series to make sure that we all become safe nurses. So what are we going to discuss today? We are going to discuss few questions around fall prevention, prevention of HAPU, surgical safety, and infection prevention. Last time we addressed about 5 domains over 2 hours, and this time we reduced the questions a little bit. We kept to the most practical ones, and let's see that this is going to help each one of you. So with that prayer that let's not do no harm to our patients. So the first aspect is fall prevention. And though we say that fall prevention is for everybody, it definitely falls on the nurse's shoulders maximum, because we are the people who are spending the maximum time with our patients. So that is the first segment that we are going to address. So as I ask the questions and I put the choices on the screen, please select your best answer, so that way you will know that once we discuss that whether your answer was right, and give yourself well done. And if the answer is not right, we will be discussing why it is not right also, right? So let's start with the first question. So, fall risk assessment. So, fall risk assessment, what does it do? Does it promote implementation of appropriate interventions based on need? Does it notify all key healthcare staff of a patient fall risk? Reduces potential of serious harm or even death through screening? Or is it all of the above? So I will just give 3 seconds for you to choose yourself. What is your answer? Tick tick one, tick tick two, tick tick three. All right. So let's look at the answer. Or is it only A and B? Oh, okay. There is one more option. So we need to think whether it is only A and B or all of the above. Oh, let's find out. And if you have answered all of the above, so please clap for yourself and well done. Great. Now, it's very important that how we do the fall risk assessment. And if we do it very diligently and the rightful way, this actually gives you to plan, implement, and prevent any patient harm. And fall is one of the events that we definitely would like to avoid when patient is in the hospital. And if patient falls and they sustains permanent harm or they result in death, they are sentinel events. So obviously we don't want that to happen. And the assigned nurses, they take the maximum responsibility to ensure that your patients are kept safe. So let's look at the second question. So when, 1 second, let me move this around. When completing frequent or hourly rounds, and many of you must be aware of the concept called hourly rounds, that you only need to peek in the room. So I am going every hour or 2 hours to look at the patient. How is the patient doing? So I only need to peek in the room to ensure the patient is not doing anything that could cause a fall. Is this statement true or false? Yes or no? Think about it, that when I am checking on my patient, am I just going to, you know, peep and say, okay, is my patient all right, or do I need to do anything more? So please, tick tick one, tick tick two, tick tick three. Found your answer? All right, let's go. It is definitely false, because when you have a patient who is at risk for fall, you need to go near the patient. Very important. And also the hourly rounds has got certain concept, that is called the 4 P's. It is called pain, poti, position, and possession. One of the reasons for patients to fall off is that they need something, so they try to help themselves and then they fall. So main reasons are either they are in pain, or they want to use the toilet, or they want to change their position, or they want to bring some of their position. Maybe they want to have a glass of water, they want to reach out somewhere. So when they are trying to do that, the patient can fall. So when you are doing rounds, you need to go near the patient and find out if the patient is comfortable, do they need anything, and you can do also your safety check. Safety check means just to make sure all the things that you want to do for the patient to prevent fall is everything done. One casual look and you can make sure that everything is in order. So it does not take too much time. So post fall huddles. Now, for all those people who are first time hearing this word, let me just explain what it is. So, God forbid that there was a patient who fell down. And if the patient falls, immediately after that, soon after the patient is settled and taken care of, it is expected the team comes together and they quickly discuss what happened, why it happened, so that you don't forget what exactly led to patient's fall. And this is a very serious event that can happen in a hospital. So you need to come together and do a huddle, and even the nurse who is assigned to the patient must be part of this huddle. And it goes, this is the same learning all of us have, is that very closer to the event, if you are able to discuss, the seriousness and the recollection of the event will be much more. So post fall huddles promotes communication with caregivers and the family and the patient, assists with identifying process improvements through the use of data, provides key information to correlate trends, don't really provide any value with preventing falls, only gathers data. So you are expected to take the best answer. So let's go 1, 2, 3. I hope you selected your answer. And did you think that all of them are correct? All right, let's see which is the correct answer now. These are the top 3. So when you do a huddle, you also make sure that you are speaking to patient. You will not call the patients to the huddle, but you would have already spoken to the patient and family and all the caregivers involved in that. And then you are able to find out what needs to be improved. And also you are able to discuss about what happened before and what is going to happen in the future. So post fall huddles are important, and in many hospitals this will be called as, sometimes they do a RCA would take even more time. Huddles are not taking that long a time. May I request everyone to mute yourself, please? Hello, please mute yourself. Here in the class, please, Prince Jose, please mute yourself. All right. So the next question. Mr. John, 70-year-old man, admitted in hospital with complaints of diabetic foot ulcer. He is 90 kgs and he has developed diabetic retinopathy. While assessing fall risk for this client, what nursing intervention should you keep in mind? Keep nurse call bell within the reach of the patient. Keep the side rails up and wheels of the bed locked. Check any device inadequacy. So which is the... I'm requesting everyone to please keep yourself muted so that we don't disturb others. Avoid clutter or clutters in the room. So which will be the answer? Is that going to be A, B, C, D, or E, maintain hourly rounds? What is it that going to be? Ouch, it came up with the answer. I'm so sorry, didn't give you 3 seconds to identify the answer. So let's look at this, why we need to do all these things. So when we are going inside a patient who already is 70 years, he is already vulnerable. He has got diabetic foot ulcer, that means he is not very freely mobile. 90 kgs, maybe he's little on the heavier side. And diabetic retinopathy, that means he might be having problems with eyesight. So his risk is not just one, not just the age, he has multiple other things. So this is very important for nurses to know the client very well, client or the patient. What is the diagnosis? What are the other problems? So just in one case study, you can see that. Prince, can you please mute yourself? Repeatedly you are unmuting. Please make sure that you're muted. So keep the side rails are up and wheels of the bed locked. Usually there are 2 things that happen. I have seen it in my own experience. One is that we raise the side rails.
म्यूट नहीं है. हाँ.
I'm requesting everyone, please stay off the video and keep yourself muted. If we find you repeatedly not following what we are saying, we are going to remove you from the session. So please keep your video off and audio off, both. Let's not distract the participants here. So please stay muted on audio as well as on video. Thank you very much. So sometimes we keep the rails up without ensuring that it is locked. And the other common thing that I have found in my experience is that the bed locks were not checked. So the bed was mobile. So that can lead to patient falling down. And check any device inadequacy. That means any devices that is being used on the patient, even a call bell. call bell that you are keeping within the reach of the patient, it should be working. So you have to make sure that it is working. So when I was a staff nurse, it was my routine habit that whenever I start my shift, I will check my patient's bell, and I will also ensure I'll give the bell to the patient and say, sir, can you just use it and show me that you know how to use the bell? And where do I position the bell? So these things are very important. That what are you doing? So you look for any device inadequacy and avoid clutters. Now this is very, very important. We can't expect patients to be totally, queued and making sure that the room is kept as clean as they would keep in their organization, in their home. The videos are, please, it's distracting me. Please make sure that your videos are put off. Thank you. Ishita, can you please look into that? Can you mute everyone, please? Ishita, are you there?
Yes, ma'am. Yes, ma'am. Doing it.
So avoid clutter. So when you go in the room, if you find the cardiac table is somewhere, the footstool is somewhere, take a moment, put them back exactly where they belong. This always will help you to protect your patient, right? And maintain hourly rounds. Now this is a concept, it's a evidence-based practice. There are multiple, papers which have been released that when you do an hourly round on patient, you reduce the fall rate by almost 50 percentage. So this is very important, that one need to know how to do a proper hourly round. As I told you a little while ago, the concept that you can hold in your head when you are doing an hourly round is, whenever you go to the patient, in your mind you're going to check, is my client expected to have pain? Then you will ask about the pain. Does he need any help with the pain management? Second thing is potty. Potty means any toilet needs. Does he need to go to the toilet? Does he need urinal? Does he need bedpan? You're going to inquire before the patient rings the bell. Interestingly, if you do the hourly rounds, your call bell rates also come down to more than 30 to 40 percentage. So this is something that you can keep in your mind. No need to wait for the hospital or the nursing department to start, complete training on 4Ps or anything like that. No, you as a nurse, you can always do this on your own with your patients. So we got the pain and the potty position. That means is the position of the patient right. This particular concept is useful to reduce falls, and it has been proven that you can reduce falls by 50 percentage. You can also reduce pressure ulcers by 50 percentage, because whenever you go in, you are actually checking if the patient's position is okay. Has he slid down the bed? Is everything that is required, all the drains and all the connections are all right. So it adds to a lot of safety, not just fall. So you are acutely scanning the environment, and you are making sure that the patient is not in pain, patient does not have any toilet needs, position of the patient, position of many other apparatus and equipments which is around the patient. And the last one is possession. Possession means, does this patient need his glasses or water or whatever that he or she would need, that it is nearby so they can reach out, help themselves if required. And also position and position, always remember, I will check the call bell also. So when you do this on a continuous basis, the time that you spend doing it is definitely going to be less. You just go in, quickly check all these things, and you move on to the next patient. So these are all very practical tips that I am giving to you. So just keep that in mind, and when you actually start practicing being a nurse, this all will come handy. So, Mr. John, a 70-year-old man admitted to in hospital, complains of, diabetes. The same case study as last time. One of the most common gap in managing patients at risk for fall is, this is one of the most common gap. I have seen it as a, nursing administrator, and that is not keeping the call bell within reach, poor assessment, lack of patient family education, slippery floors, negligent nurses. What is the most common gap that you think that we usually have when we are actually trying to prevent falls in patient. So select your best answer and let's see whether you got it right or you are saying that all of the above. So let's see one of the most common gap. So let's go try find out what it is. So it's interesting, I have done root cause analysis of many falls in my career in my hospital. One of the common thing that I find is that the patient himself who is at risk for fall, they are not aware that we have identified them as at risk for fall, or the family has not been told. We usually tell them, don't get up from the bed. If you need anything, call me or call the call bell. And we think that they understood what it is. So it is very important to explain to the patient, excuse me, Mr. John, if he is fully aware, you can tell the patient, excuse me, Mr. John, our risk assessment has shown that you are at a high risk for falling when you are in the hospital. So may I request you to take care of these things, all your fall prevention education you can give. And on top of that, very important, family, if they are there, you will educate the family as well. And the last but not the least, my dear nurses, is that whenever you educate patient, please use teach back. This is very, very important. In the last session we talked about communication, we did talk about teach back. Teach back means ask the patient, Mr. John, what did I tell you? Can you please explain to me what I have told you? इन हिंदी यू विल से, मिस्टर जॉन, मैंने अभी आपको समझाया बेड से नहीं गिरने के लिए, तो आप मुझे बताएंगे कि मैंने अभी आपको क्या क्या बताया. आई नो these two languages, so definitely I'm using these two. So in the language that patient understand, ask them to teach back. In that case, you can ensure that the patient and the family, they have understood what you are trying to tell them. Now, when are the fall risk assessments done? When do we do the fall risk assessment? So let's look at when do we do the fall risk assessment. At the time of shifting to OT, we do it on admission, when received from another unit. My dear young nurses, please pay attention to the screen and keep yourself muted so that you are able to learn. You have taken time to be here, so don't waste your time. Let's learn it together, all right? So at the time of shifting to OT on admission, when received from another unit, at the beginning of every shift, when the patient condition changes. So we need to select the fall risk assessment at what all occasions we are going to do fall risk assessment. So let's look at that. Okay, have you selected one or more, whatever that you have? So let's see. Or is it all except A? What will be your right answer? Right? Or it is all of the above. All right. So the answer is going to be all except A. Particularly when you are shifting to OT, you don't do a more scale. Modified more scale. More scale is the risk assessment tool that most of you have learned or you are using it. But you have to do risk assessment on admission and beginning of every shift. If you have received a patient from another department, another ward, you will do your own assessment. And if the patient condition changes, for example, the patient was not at risk, patient went for surgery and next day he is on bed. So his risk, the more scale will show that now he is at risk for fall. So when the patient condition changes or the patient had some event, patient had near cardiac arrest or the patient was resuscitated. So anytime the patient condition changes, you are supposed to do a assessment. So that is when you do fall risk assessment. So that we completed with the fall risk, the most basic questions. There can be more questions asked. Now we are going to get into the next segment, which is the infection prevention. Infection prevention is a very huge topic, so it's very difficult for me to even decide that what questions I'm going to ask. And in my experience of training thousands of nurses from 2012, this domain is still not completely in place. Not everyone is very thorough with the basics of infection prevention, the principles, the infection prevention and control. First is to prevent, then only control. We are not there to give infection. So we know the burden of infection is very high. So your 1 in 10 patients can be infected, or they can pick up hospital acquired infection. Question number 1, your patient is being transported to special procedures for a PICC line placement. The patient is in droplet precautions. What are your nursing actions to ensure proper transport of the patient? So when patient is on isolation, you are expected to have certain precautions. So we already know patient is on droplet precaution. So what do you take care? So inform the receiving department and place a surgical mask on the patient. Place an N95 mask on the patient and notify the receiving department. Cancel transport and notify the physician for further orders. Notify the receiving department, place goggles, gown, mask on the patient. So what is that you are going to do if a patient is on droplet precautions? So for that, you have to know what is droplet precaution. So please mute yourself, ladies and gentlemen. So the answer is inform the receiving department and place a surgical mask on the patient. Droplet is what? When you sneeze or cough, when you're breathing, you leave heavy droplets in within your 6 feet. I mean, all of us now know by now, because COVID-19 taught us to keep a distance of 3 to 6 feet to protect yourself. So, proper surgical mask worn by the patient, and also the person who is taking the patient will also be definitely wearing the mask. So, that is the right answer. So, let's go to the next one. A patient is diagnosed with hepatitis A and is incontinent of stool. What type of precaution should be initiated? Now, it's very important to know what is hepatitis A and when the patient has got stool. So, what is the route of transmission? See, usually the isolation precautions are decided based on the route of transmission. That's how we decide whether patient is going to be on contact isolation or respiratory isolation, airborne, yeah, droplet, yeah, mix of both, or what it is. So let's see, what are you going to decide? Are you going to put the patient on contact isolation, standard precautions, droplet, contact and droplet? Up, the answer came up. Contact precautions, my dears. We know that this is hepatitis A GI, right? Usually the transmission is through the stool, contaminated hands. Then from there it can get into hands or anywhere. And that's how this is the GI route, right? So it is contact isolation. There is no droplet or airborne over there. Now, just a quick one. I don't think we're asking a question about standard precaution. Please remember, standard precautions are a set of practices that you adopt to make sure that you and your patients are safe, and that is applicable for all patients. Standard precautions is on all patients. There are 2 layers of precautions that you do in infection control. One, standard precaution for all patients, and on top of that, you will add transmission based precaution. So, standard precaution, very simply put, you're always looking at the patient, even if you don't know whether the patient is infective, it doesn't matter. You consider that if you have a risk of exposure to body fluids, then you will use gloves, gown, etc. So that for that you don't need to know whether patient has got any condition at all. So once you know the patient has got a risk of transmitting diseases to others, you will know which is the route, and based on that you will have your precaution. So patient with disseminated herpes zoster. Before I put down the answer, I have a question to all of you. What is the other name for herpes zoster? Can you put it in the chat box, please? Herpes zoster, what is the chat box? Chat box, can do. Herpes zoster, another name. We have students here, so I'm sure that all of you kind of remember this. No, it is not chickenpox. Chickenpox is varicella. Right? Melvin, what are you writing? Nugget? Or you are writing nahi, you don't know? Yes, anyone? No one? Students? Get together, fungus. Oh, you need to go back and read. Herpes zoster, the other name is shingles. Maybe you should go back and read a little bit about herpes zoster. So if you don't know, it is going to be a problem. The answer also you will have issue. So patient is on routine tracheostomy suction. Select the appropriate PPE you will wear. PPE is personal protective equipment. So what are you going to wear when you're going to do the suction? Surgical mask, goggles and gown. N95 mask, face shield, gown and gloves. N95 mask, gown and face shield. Surgical mask, face shield, gown and gloves. The answer is N95 mask because herpes zoster is an airborne transmission. So you need airborne all precautions, and you are also doing a aerosol generating procedure which is called tracheostomy suction. So you need to protect your face shield, N95 mask, gown from because it is aerosol generating procedure, plus this one also has contact, gloves because disseminated herpes zoster means you have lot of lesions. So there is contact plus airborne precaution is required when you are looking after such a patient. Let's move on. You are providing care to a patient with Clostridium difficile. C. diff is Clostridium difficile. While we are discussing, if you know the correct spelling, please put it in the chat box because that's a slightly complicated spelling. After removing the appropriate PPE, so you have done care to the patient and you removed your PPE, what would you do? How would you do your hand hygiene? Using hand sanitizer, I can use hand rub and clean my hand. And using soap and water. Using soap and water only if hands are soiled, but can use hand sanitizer because you must have learned that hand washing is required when your hands are visibly soiled. Using either hand sanitizer or soap and water, you can use any one of them. So pick your answer. So I'm going to look at the chat box with this particular answer. Can I see your answer? What is the option? Okay. All right. All right. So some of you are picking the right answer. The right answer is using soap and water. Please remember that this patient, any contamination you cannot remove with hand sanitizer. It is resistant. So you have to use soap and water to make sure that your hand is clean of Clostridium difficile. The other thing about while we are looking at this, please always remember another problem that all of us have is that after removing gloves, many times we don't even do hand hygiene. Forget about the Clostridium difficile for a moment. I'm talking about regular understanding. Please, it's like a mantra. Please remember, before wearing gloves and after removing gloves, you must do hand hygiene. And after removing gloves, you must, how many times you must have seen a different thing in hospital? Some of us even remove the gloves, hold the pen and start writing. One glove removed, other, the pen is, used to write. So these are actually wrong practices. So please learn that, to be safe. You also needs to be safe, and your patient also need to be safe. A nurse accidentally gets a needle stick injury in her finger as she pulled out an IM needle from the muscle. The first action is to, so in case by mistake, if you have had a needle stick injury, and this particular action is something that we all will do because this is not a routine cause of needle stick injury. This is not negligence, just that maybe for a second she was not paying attention. So what are you supposed to do? Report the accident to charge nurse. Wash the area under running water and do not squeeze it. Clean area with povidone iodine solution. Irrigate the wound with sterile water. So what do you think? What are you going to do about in case you get a needle stick injury? Some of you are quickly putting down the answers. So correct. Wash the area under running water and please do not squeeze it. No squeezing, no sucking. Don't do anything. Just put it under the water and then you can report to the emergency. You would have to report to your charge nurse, that is the for sure. But the first action is just go to the tap, put it under running water and do not squeeze and report immediately. Very important to report. Don't assume that my patient has got no positive test, so I don't need to worry. No, it's for your own protection that you must report it. The three most important aspects of hand hygiene are, so when you do hand hygiene, okay, hand hygiene includes hand washing and hand rub both. So what is it that you are supposed to be remembering? The three most important things: amount, product and expiry date. Number two, amount, duration and friction. Whether hands are visibly dirty or not. Time, steps and amount. So what do you think that we need to keep in mind? When you do hand hygiene, what is that we have to keep in mind? Okay. Mhm. So some are selecting D, some are selecting the. So friends, the answer, the best one is amount, duration and friction. So let me tell you why. So I was doing a session for somebody else and I asked them to demonstrate hand hygiene. Okay. So typically there is a need, let's say when you do a hand rub, you are supposed to take an adequate amount of hand rub. So when if I ask the 150 plus people sitting here, I will probably get at least 20 different answers. So what is that you are going to do? Because many say that I should press the hand rub twice. So now the twice pressing can differ from person to person. Okay, a small thin person will only press like this. Somebody tall and fat, when they press, more will come out. So I'm going to give you some very practical tips that you can always remember without even remembering. It has to become a practice. So all our hand sizes are different. So the hand hygiene or the soap, whatever that we use, it is expected to touch all the areas of our hand. Then only the hand hygiene is complete. So for that, you need adequate amount of hand rub. So whether it is two puffs, you are not sure. So best way is, based on your hand, make a cup of your hand. Cup. Make it like a deep cup of your hand, and make sure that cup is full. Whether you are pressing twice or thrice, it doesn't matter. You have enough of your hand rub here or you have enough of your soap here. All right. After that, let me duration we usually remember 20 seconds. That's what we say. Okay, minimum 20 seconds. So I will always tell you, please remember 30 seconds. That way you never go below the duration. Always remember 30 seconds for hand rub, hand wash. Okay. So now how do we know that we will spend 30 seconds? So typically the best way is, you can do all the actions 5 times. Five times when you complete all the steps, it will give you 30 seconds. So that steps is fine. So you maintain the duration. Now the last bit is the most important thing. Why I say steps is not right. friction. So though all of you can see me, so if you do, I usually call it as the namaste activity. Okay, let's say you do a namaste. All of you, I know you're not on video, maybe you can try. Just do a namaste and see that there are places inside your hand which is not touching each other, especially this area. We are not touching each other. So when we are doing this action, it is not necessary that it is touching. So it is very important that we use a friction movement. Friction means we ensure all the surfaces are touching each other. And if you work by each step, you will realize that, unless and until you are consciously trying, mostly they usually people demonstrate like this. It's like very casual. You can see that there is no friction that's happening. And this hand rub that has come there, it has to stay till the time you finish. If it is already dried up, it is no use. That's why the volume is very important, how much you have taken. So friction part is very important. One more thing that I would like you to take away from here, though the training, many times the training video says that you rotate your thumb, but please remember this area and this area is not touched. So if you slowly do your steps, you will realize this area is hardly touched. Next time when you're washing your hand, you can always see the lather of your soap. Try with the soap, just see that where all your soap has not touched completely. It's very easy to learn that way. So I always teach this way. When you're doing the thumb rotation, do this 5 times. That means run your hand from here to, and this one from the base of your thumb. So it's like one action and you are rubbing it, you are rubbing it 1 2 3 4, 5 times. Similarly on the other side, I'm having definitely nails, so I will not be able to clean my fingertips, so mostly people are doing this as a part, almost like a dance, they go down like this. But if your friction, if your two surfaces are not touching completely, that means that is not right. Okay, so please keep that in mind. That's an extra bonus information I'm giving. You are teaching a new nurse about ways to prevent the spread of infection. Included in the instruction would be that the cycle of infectious process that must be broken, which may be accomplished. So primarily, how can you break the chain of infection? So what is the most important thing? Hand washing before and after providing client care. Thoroughly cleaning the environment. Wearing PPE when providing client care. Using medical and surgical aseptic techniques at all times, which would be the most appropriate answer. Hand washing is considered to be the cornerstone of infection prevention. So please understand, if we can always practice before and after touching the patient, if we are going to do hand hygiene, other things are also important, by the way. Thoroughly cleaning the environment, wearing appropriate PPE for appropriate care, not always, then medical and surgical asepsis as the procedure demands it. So imagine there is a lot of things that is going on in our head when we are caring for the patient. We will know what to do only if we are thorough with the basic principles. And we are today only looking at some basics. Otherwise, one infection control basic class will take at least 8 hours, not 1 hour for sure. So now let's move on to the next segment. This is WHO surgical safety checklist. I got the WHO because that's the most common checklist that is being used in all the hospitals. Now, this particular checklist was introduced now. It has been over 15 years, I guess. It was released by WHO, and now it is universally accepted across the world. And in the Indian hospitals also, this is being used, and it is mandatorily to be used as per accreditation as well. So that is surgical safety. We are only going to discuss about the nurse's role. Only few questions I have put in here. So let's try to understand them. Okay. In the surgical ward, patient X and patient Y were posted for TURP on the same day. Patient Y was a high risk case and was anticipated to be sent to OT first. The nurse receives a call from OT to send the patient posted for TURP. She sends patient X. So I hope you understand. A wrong patient is being sent to the OT. And in which step of surgical safety checklist should the team identify the wrong patient has been sent to OT? At what level can you catch this mistake? That is what it is. Whether it is going to be in sign in, or it is at sign out, or it is time out, or it is time in. So, which segment this particular error can be caught? Let me look at the answers. Am I getting some answers now for this question? Okay, all right. Same people tend to be answering this, correct answers. Others are all keeping quiet. All right. It is definitely sign in. Sign in happens when the ward nurse reaches the pre-op area and when they receive. So that's the place that they can identify that they have got the wrong patient. So I'm not going, we don't have time to discuss the entire checklist, but please remember that the practices that you learn must be followed. This is very, very important. Now, a surgical marking is mandatory for some of the surgeries. So, what is the, cases where you have to do the surgical mark? Surgical marking is mark the surgical site with an permanent marker. So there are sterile pens also available to sign. The surgeon or the surgical team will do that. Laterality, multiple structures, spine, only at the organ level, or it is all of the above. So I'm just trying to look for some answers that's coming up. Hello, friends. Oh, there is one more option. All of the above except D. Okay. All of the above. At organ level, you don't do that because we have, unless you have two organs. So unless you thought that kidney left and kidney right, unless you have two organs, it is not required to have surgical marking. But laterality, if the right and left, if it is there, you will. Multiple structures, that there are structures nearby. Spine is very important to know. And which leg, right or left leg. And that's where we don't need to sign off in the organ level. But laterality is a very easy thing to remember, right and left. Spine has got multiple levels. So if you have multiple structures, multiple levels, surgical marking has to be done. It is not the responsibility of the nurse, but the nurse should remind the surgeon that it needs to be done. This is a very, very important thing. I'm very sure many of you have heard stories where the wrong leg and the wrong side has been operated. The famous case of Sridevi's mother, who was in the best of the hospital in US. She had craniotomy on the wrong side. Can you imagine? So that is how mistakes happen. So it is always important that we follow the right thing all the time. Why do we still have wrong site and wrong surgery? So let's understand what can be the reasons for wrong site and wrong surgery. Because we do not report near miss, fear of raising an alarm, insufficient communication among team, checklist is considered as a tedious task. When error take place, often it is the person oriented instead of process oriented. So when an error take place, the answer, what it means is that it usually the solution is person oriented, not process oriented. Oh, all the answers came up together. I'm really sorry. I should have asked. But anyway, so let me go through one by one. Just a while ago, we said, no, the wrong patient reached the OT and then at sign in, you found out the wrong patient came. Will somebody report that Mistake, I doubt, because that's a near miss. Something could have really gone wrong if the sign in did not happen properly. So we don't report near miss. Or we don't report because we are afraid to report, or we are worried that I could be asked for explanation, or I could be punished. That could be a reason. Or there is not enough communication among teams, so that especially in the surgical safety checklist, the timeout is a very very important time, that everybody communicates and says whose role, what role, whether they have the right patient, the right x-rays and everything. So maybe there's not enough communication, and the checklist considered as a tedious task. My famous line always is, don't make your checklist a tick list. No, always read the things in the checklist and make sure that you are complying with that. This is very very important. And when error take place, this is very common, that the person is held responsible. We seldom spend time to look at the process. This is a very common phenomenon. So as student nurses and as bedside nurses, I would only request one thing: do not feel afraid. Please speak up and say that either this is a near miss or an event, it doesn't matter, or you will say this is an unsafe practice. When we are doing this, we are increasing the risk of errors. Please speak up. This is very important, right? So that kind of completes the surgical safety checklist. Now we go to the last segment, and that is pressure ulcer. Another problematic area for all nurses, and we know that we always struggle to make sure that we are preventing hospital acquired pressure ulcer, known as HAPU. That's the short form of a hospital acquired pressure ulcer. It's not only painful to the patient, it increases the cost of caring for the patient. It also increases the manpower requirement for patient care. It increases the work of the nurse. So I think it is always smart for nurses to be on the preventive mode, rather than in the curative mode, because pressure ulcer better to prevent. A male patient who is admitted with congestive heart failure reports that he spends all day at home in his recliner, even sleeping in it. Which area of the patient's body is checked first for possible skin issues and pressure injury risk? So, knowing the patient's condition, where are you going to check first? The ears, the toes, the sacrum, or the trochanters? All of them are pressure risk areas, but knowing the history of the patient, where are you going to check first? So obviously it is the sacrum, because the history says that he is always sitting on a recliner. Recliner is a sitting position most of the time, little bit backbone. So most of the pressure will be in the buttocks. So you are going to look at the sacral area to see whether he has received started. Even trochanter is at risk. Ears, toes, everything is at risk. But toes is probably the least, of the risky area for pressure ulcer. But ears, yes, when you are sitting in same position, you can get pressure also there on the ear. You are lying down or you are sitting, both side, both way. The common reasons for developing HAPU are: select all that apply, neglecting the turning of patient, pressure, shear and friction, poor nutrition, hydration in at-risk patients, all of the above. So what do you think is the best answer here? The best answer is B, C, and D. I would not like to believe that the nurses will be neglecting to turn the patient. And also, turning the patient has to be scientific. Okay. The most common reasons are, unrelieved pressure, shear and friction. And I would definitely like to emphasize on nutrition and hydration. Patients who are identified at risk. So what is the scale that you use to do the risk assessment for pressure ulcer? Can you put that in the chat box? What is the scale that you use for patients who are at risk for pressure ulcer? What is this scale risk assessment tool that you use? Okay, very good. Braden, yes, Braden scale is what that you use. So go to the next question. The following is one of the commonly overlooked factors in prevention and healing of pressure ulcer. So, in case the pressure ulcer happened also, what is that you are going to do? Commonly overlooked factors: repositioning, nutrition, moisture, and all of the above. So, I think you must have guessed because I kind of alluded to the answer in the previous question. Nutrition. I want to say just a 5 seconds emphasis on this. Unfortunately, most nurses, we are so much worried about the medications, the lab test, and many other things without actually paying attention to the most basic need of the patient. If you look at the Maslow's hierarchy of needs, it is air, water, food, right at the bottom. Air, obviously, we take care. If patient has got breathing difficulty, you'll make sure that you give him oxygen, prop him up, we do that. How many of us seriously look at what the patient is eating, what he's not eating? Is he drinking enough? So usually drinking enough happens when the doctor writes intake output chart. How many of the nurses decide to initiate an intake output chart? Writing that did the patient eat enough? When I was trained to be a nurse many years ago, I was taught that we have to document how much of the food portion did the patient take. So we were supposed to write 50% of the food served did the patient take, 40%. So anything, we will be worried if the patient has not taken at least 80% and above of the food that was served, because the food has been measured and calorie wise prepared as instructed by the dietitian. And if a patient is not taking all of it, we should be worried. And if the patient is not leaving almost 50% untouched, writing in the nurse's note that the patient did not eat well is not good enough. We nurses need to plan. So we are going to inform the dietitian, we discuss with the doctor, I think the nutrition is not going well. That means patient is already at risk for pressure ulcer. He will develop pressure ulcer faster, because we know low hemoglobin, low protein, low albumin are there, increasing the risk of pressure ulcer, and definitely they will not allow the pressure ulcer to heal faster. So, isn't it smart that we should pay attention to the hydration and nutrition of the patient? Moisture and repositioning is they are also important, but the most neglected area is nutrition. And whether it is written in the book or not, take it from me, with 40 years experience, I know that this is one area that we are not paying enough attention: nutrition and hydration both. Oh, I'm so sorry, by mistake I stopped sharing. Okay, so let's go to the next question. Repositioning of patient should always be accompanied by. So when you are repositioning a patient, what should you do along with that? Accompanied by pillows, skin assessment and skin care should be done it is every 2 hours, or ensuring that the pressure alternating mattress is working. What should be your answer? B and D, or all of the above, or what is that you would like to have? A, B, and C. Which is the right answer here? A, B, C, D. Okay. F, A, B, and C. Okay. So let me tell you the answer from my experience. You might be looking at it very theoretical. Repositioning, the most important thing that you should do along with the repositioning is that you have to make sure that you assess the skin and do the skin care, not just simply turn the patient. You have to make sure that you are able to observe the skin and give care as required. And the D, very common thing that happens in hospital is that we do give pressure relieving mattress or pressure alternating mattress. In very simple terms, everybody calls it as air mattress. Unfortunately, the motor will be on, but the connection will be off. So the mattress will not be doing its work. So this is one of the practical problems that I always have. Pillows is something that you will take to reposition. Now, should be done every 2 hours. I will not insist on that because there is nothing which says, it says that minimum 2 to 3 hours, but please remember that you may need to turn a patient even more frequently. So that is why skin assessment is very important. So after 2 hours, when you turn the patient, when you wash the skin, you find that it is redness is more than what you will expect. That means that this patient needs more frequent turning. So I hope that was a new learning for all of you. How soon can a pressure ulcer develop in the chair-bound patient? So that's a knowledge that we all must carry. In around 2 hours time, in as little as 60 minutes or 1 hour, varies from patient to patient. 3 hours if they are sitting on padded chair. So what could be your answer? Please remember, this can happen in as little as 60 minutes. Though it may vary from patient to patient, but it's very important to remember a chair-bound patient can develop pressure ulcer in less than 60 minutes. So when we take patient on wheelchair or chair outside, we put them in the sun, sometimes we take them for round, and they are not able to shift their weight. That means these patients can develop pressure ulcer in as little as 60 minutes. So I think that was the last of the question, and I'm just looking at the time. And thank you very much for being here. So what is next? So tomorrow, ladies and gentlemen, we are going to talk all about mask and respirators so that you understand what kind of mask, what. So we are not going to only talk about the mask that is being given to patient. We are also going to talk about the general mask during the COVID time. What mask, what is their peculiarity, when do you use, what do you use. So a little bit more for your own personal safety also we will be discussing about the mask. So please, in case you want to check out our other training videos, so please go ahead. You can visit www.cygniahealthcareacademy.com. Thank you so much for all the people who have visited and taken their free courses, and some of you have even taken the paid courses. Thank you for being there. And in pursuit of patient safety, there is one session loaded with 50 questions. You can attempt that and you can definitely download your own certificate from there. So thank you very much for being here. See you all tomorrow at 11 a.m. So let me just stop recording here right now.